Blastomas are rare in children. See, the picture is typically that of a dentigerous cyst if you saw the X-ray. And he was actually, this is an outsider patient. He was coming from a very backward area of Purulia. And in fact, one of our ex-matrons was having a rectal cancer. She was, an anterior section was being done. Her son-in-law knew this patient somehow. He was being treated at Ahmed Hospital. So they had done the CT, FNAC and all that. So he had come with that. See, this is the typical dentigerous cyst-like appearance. So now it could be possible that this was an ameloblastoma which had occurred in a pre-existing dentigerous cyst, but it could also be a de novo ameloblastoma of this kind. So this is the typical unerupted tooth, and here is the ameloblastoma. In fact, we were still having doubts as to whether it was an ameloblastoma or not. The radiological picture was so classically that of a dentigerous cyst. So initially we did a curettage, we repeated the biopsy, but it came out as ameloblastoma, and therefore we decided to go ahead and do the excision. Now, the reason why the free fibula was not done was because it was involving the neck of the condyle. These tumors, the reason why they are called adamantinomas is because they are very adamant to treatment. So they keep recurring unless you give them a proper margin. And therefore, obviously you could not afford repeated those condylar plates with the titanium prosthesis and all that. So we abandoned the process because there was no condyle to attach the free fibula to. However, he is doing pretty well even now because he is on follow-up. And in fact, recently we had a similar case of a dentigerous cyst in an adult, happened to be the mother of one of our, Shaunak's mother actually. And because of this case, we were a little apprehensive, but we treated it like a dentigerous cyst, and the diagnosis has come out as a dentigerous cyst. Though the picture the radiological picture was almost identical. But in dentigerous cysts, of course, curettage is sufficient treatment. But for these cases, one has to be very careful. We have to take margins, otherwise they tend to recur. These patients, unless you do even with unicystic ameloblastomas, which have lesser chances of recurrence, the recurrence rates are still as high as about 25-30%. So, since it was a very rare case, we decided to present it.
Some light on the first two cases also?
Light that.
Well, yeah, basically, see, one of them was an eventration of diaphragm with a organoaxial rotation of the stomach. So, in fact, he has said everything that was to be said. And the only thing that one can highlight is the fixation of the stomach, what is called a non-anastomotic gastrojejunostomy. The stomach was fixed posteriorly to the jejunal loop without actually doing an anastomosis, so that it does not re-rotate further. And in the first case, of course, it was a classical diaphragmatic hernia which was repaired. In the second case, it was an eventration of diaphragm with an organoaxial rotation. Once again, in the first case also, the CT diagnosed it as an eventration of diaphragm, but when we went in, we found that it was not an eventration, it was a classical hernia. So, at the end of the day, we still have to keep our eyes open when we enter, because CT scans may not always be the final word.